Hello, everyone, and welcome to the Clinician's Perspective. My name is Aman Patel, and today we have Dr. Sanjeev Phatak here with us. He finished his MBBS from Ahmedabad, Gujarat, and he did his MD PGDM from UK. So, hello, Dr. Sanjeev Phatak, and welcome to the podcast.
Thank you, Dr. Aman. How are you?
Yeah, I'm doing good. So, let's start with the very basics of clinical side of medicine. So, how important is the basic history taking?
Well, in any field of medicine, the things start from the history. Though the technology and everything has come, history still remains of prime importance. So, if you miss certain points in history, you will never be able to come to the correct diagnosis, and that stands true more in the field of diabetes.
So, there's a question that I have in mind. While I was doing my internship, I used to find that the basic history taking time is around about, let's say, 2 to 3 minutes because of the large patient population. But at your clinic, which is more of a private institute, what is the basic average history taking time there?
Maybe 20 to 30 minutes, if not more. And that starts with our diabetes nurses or the medical officers who take the detailed history and then they represent it to us. So it is very, very important.
In your opinion, does it really affect the diagnosis in long term?
Yes, let me tell you that if someone who is young and comes to you with diabetes, what we very importantly ask is that since how long the person is having diabetes and how was it diagnosed? According to me, this is the most important question, that what was the symptom or what were the symptoms at the time of diagnosis, because that can give us a diagnostic clue that what type of diabetes the person is suffering from and how progressive the disease is. Suppose someone has come to you with no symptoms and his blood sugars are 250 or 300, compared to that someone who has come to you with severe symptoms like polyuria, polyphagia, polydipsia, the classical symptoms, which would immediately signify that the symptoms are because of the glucotoxicity and this person is having insulin deficiency. So you need to treat that patient and investigate that patient in insulin deficiency manner compared to the insulin resistance where you do not have any of these symptoms.
I agree. I
So
agree.
history is, I would say, extremely important.
So, what about the examination part?
Yes, examination part. There are few important points that should never be missed in a diabetes patient. One is, of course, diabetes today means cardiovascular disease tomorrow. So, cardiovascular system examination, including the vitals, the pulse, blood pressure. You must be knowing that about 60 to 70% of the diabetes patients have hypertension as well.
Yes.
Type 2 diabetes, I'm talking about.
Yeah.
And majority of the population, what we deal with is type 2 diabetes. So, blood pressure measurement, not only in the supine position, but also in the standing and sitting position, in both the arms is very important and which is very, very commonly missed. Palpating the peripheral pulses is also of great importance because peripheral arterial disease is not that common in Indian population, but also not uncommon.
Mm-hmm. I agree.
And peripheral arterial disease will give us a clue towards atherosclerosis also.
Mm-hmm.
Or about carotid bruit,
Yeah.
which should not be missed because it is again a sign of atherosclerosis. And then the cardiovascular examination also includes the basic auscultation, which nobody is doing these days. So these are important things. Liver disease and kidney disease have also become very important these days. So whatever physically you can examine, you should try and take into account while making a diagnosis and also for assessing the early complications.
I agree. Uh, According to the newer trends in diabetes, specifically to the age of the patient, what do you think are the trends that are right now?
Oh, well, it's a great question. I've been practicing for more than 35 years now, almost. And previously, whenever a type 2 diabetes patient would come, the age would have been 55 or 60, mostly after the age of 50. But in the last 2 or 3 decades, it is not surprising to see a very young gentleman, maybe 21, 22 years of age, coming with type 2 diabetes.
Oh,
Previously, whenever anyone came with diabetes at the age of 20, immediately the diagnosis would have been type 1 diabetes, young onset. But now we see many young patients with type 2 diabetes.
okay. So in that age spectrum that you mentioned, we have to now keep a differential in our mind regarding.
Yes. So, clinical importance of all this assumes even greater importance now because previously age was a demarcation factor that below the age of 30, type 1, above the age of 30, type 2. But now, even at a very young age, you get type 2, and at extremes of age, you get type 1 also.
Yeah, I agree. Uh, we talked about the age factor. Now let's move on to the next factor that I feel holds great importance in diabetes, and that is the family history. So, what do you have to say?
Yes, again, this is also a very important thing, especially we Indians. We have genetic predisposition to diabetes as well as the complications related to diabetes, especially the cardiovascular disease. So, family history of diabetes, whether the parents are having, whether the sibling is having, it also plays important role. Family history of diabetes and especially which type of diabetes the sibling or the parents are having, that also plays very important role. If someone in the family is having type 1 diabetes, then you have to suspect that this person can also be having type 1. So you have to obviously rule it out.
Hmm.
Family history of autoimmune disorders will also point towards suspicion of type 1 diabetes sometimes. But type 2 diabetes, again, the family history is very important. In addition to family history, you also need to take care of the epigenetic factors because sometimes the family history may not be there, but there may be the other predisposing factors which may make the person susceptible for diabetes as well as the other diseases.
Okay, so let's say you have a referral from a dermatologist regarding a patient who has vitiligo, and uh, they just want you to go through if she has any predisposition related to type 1 diabetes or any symptoms related to that. Have you ever referred a patient who already has type 1 diabetes to endocrinologist to see if there are any endocrine related disorders along with that?
That's a great question. Vitiligo, is a autoimmune disorder, and its association with type 1 diabetes is very much there. So anyone who comes to you with diabetes and vitiligo, we immediately try to rule out the type 1 diabetes. We also try to see whether the patient has any other endocrine disorder or not. Maybe hypo or hyperthyroidism. That is
Yeah.
the commonest one.
Yeah.
Sometimes rheumatoid arthritis or some other autoimmune disorder also. So whenever person is having vitiligo, I think you must have seen several patients, and that's why this question came to your mind. That vitiligo and type 1 diabetes, there is a very good association.
Thank you. Uh, so beyond the typical symptoms of polyphagia, polydipsia, what are the most subtle or let's say the most commonly missed symptoms that you would recommend a new internist like me to keep
Well,
in
this is
mind?
my favorite question I want to answer. Whenever someone asks me that what is the commonest symptom of type 2 diabetes, I always tell being asymptomatic. Not having any symptom is the commonest presentation of type 2 diabetes. Any one of us present in this room
Hmm.
or present in this building
Hmm.
can be having type 2 diabetes and not knowing. Only when you check their blood sugar, then and then you will come to know whether you are having type 2 diabetes or not. So, the commonest presentation is not having any symptoms. Routinely, the patients are screened maybe before any surgery or maybe before going overseas or maybe before any insurance claim,
Mhm.
and then they come to know that they are having diabetes. So it is very common not to have any symptoms. The other symptoms which commonly would suggest that this person must go for the testing, I would say fatigue, leg pain, itching in the genital areas, both in male and female, and then tingling and numbness, generalized itching. So these are the symptoms apart from the classical polyuria, polyphagia, polydipsia. But these symptoms should point towards suspicion of diabetes.
I agree, I agree. Uh, so moving on to the diagnosis part. Up until now, we used to rely on the typical HbA1c lab results, but nowadays we have the CGMs, continuous glucose monitors. So with the time in range coming into play, how does it affect the diagnosis of diabetes?
Well, time in range may not be used right now for the diagnosis of diabetes. It is used more for assessing the glycemic control and the glycemic variability. So, for diagnosis point of view, still the reliance is on fasting blood sugar, what we call fasting plasma glucose precisely, post glucose challenge test, but that is rarely done except in pregnancy.
Yes.
So, in practice, what we do sometimes we do post meal to our glucose and come to know whether the person is having diabetes or not. And HbA1c still remains a important assay as far as the diagnosis is concerned. But yes, you rightly said the CGMs have come and they are coming in a big way for assessing the glycemic control, for assessing the glycemic variability, and for knowing the time in range, that how much the person spends in the range, how much is below range, how much is above range.
So this is related to the diagnosis part, and we covered the basic history taking part. But let's say that you have diagnosed a patient with diabetes. The most common thing to do is to make the patient adhere to his regimen. So, what are the common steps that you take so that the patient follows his basic regimen?
Yes. Well, every patient behaves differently when it comes to accepting the disease. Some patients accept it very seriously and they become very, very panic
Mhm.
on day one, only to know that this fear was very, very transient. And immediately on the next day, they will start eating everything. Some patients really want to take this opportunity to change their lifestyle. Whatever they have done, they want to change. They want to change their diet, they want to change their daily behavior pattern, maybe work life balance, exercise, all that. And these patients really do well in the long run. But some of the patients are not ready to accept that they can develop diabetes because they always feel that they have been living very happily, they do not have any symptoms, they do not eat, overeat rather, they don't eat sweets. How can they develop? So they are in the denial phase. I think these people, you should be making them aware about the complications, not by frightening them, but by telling them the true stories. That this disease, if controlled right from the beginning, will be the easiest disease to treat. You will remain complication free and you will be able to live an absolutely long, healthy life. So, we have to make them aware that diabetes is not because of any of your fault. It is combination of so many things, genetic factors, stress, diet, lifestyle. These days in our world, the pollution, the environment also plays a big role.
I agree.
So one has to accept that now we need to change whatever was not done in the past. So diet plays very important role. So does exercise, and so does regular medication and regular checkups.
That is insightful. Uh, so you talked about complications, right? So the first step to prevent complications is to follow the lifestyle modifications, as you said. But let's say that a patient isn't adhering to the basic lifestyle regimen. Then what are the steps that you would take for the annual screening part of the microvascular and the macrovascular complications?
So let me talk about the annual screening first. So the annual screening has to be done right at the time of diagnosis, number one, and then periodically or annually, as you rightly said. What test needs to be done? Then, of course, the glucose values, the HbA1c once in 3 months, the lipid profile at baseline. These days, fasting sample is not required, you know that. So even a non-fasting lipid profile. And we need to explain to the patient that why it is important. Why it is important to reduce the LDL cholesterol to below 70. Because we Asians are at higher risk of cardiovascular disease. And after developing diabetes, the risk actually doubles or quadruples. And that is why to take care of the bad cholesterol right from the day one plays a very important role. So giving them a statin right from day one is actually recommended by all the guidelines. I'm talking about type 2 diabetes patients. Then the blood pressure measurement, obviously, the creatinine, and based upon that, the EGFR and the urine albumin excretion ratio, urine albumin creatinine ratio, USER, also plays very important role because albuminuria does not signify only kidney disease. It is also a sign of endothelial damage
Yes.
or endothelial dysfunction. So it is also a sign of early cardiovascular disease. So we need to target that also. In addition to that, fatty liver disease has become very common in diabetes people. So that also should be looked into. We look into the FIB-4 score,
Hmm. Yes.
where we require SGOT, SGPT, and platelet count, and basic ultrasound of the liver and kidneys. Hemoglobin, of course. We Indians have low hemoglobin tendency for several reasons. So these are the basic tests which I would suggest, and in addition, electrocardiogram.
I would say that you are one of the very few doctors that still practice in India and follow protocol based medicine, because most of the doctors that I have seen in government based hospitals, they are their medicine is based on the patients that they are seeing. That is very nice to see, I must say.
Thank you very much. But I think over a period of time, most of our colleagues are doing standard of care. So
Oh
I'm
yeah,
proud
yes,
to
I
say
agree.
that
Yes, I completely agree.
yes.
Yeah. Um, so moving on to the treatment part, the first question that I would like to ask is, when prescribing patients metformin, uh, is lactic acidosis the most common uh, side effect you see clinically?
Again, this is one of my favorite topic to address. Well, lactic acidosis, rather metformin associated lactic acidosis, what is called as MALA, MALA. I have seen just one case in last 34 years of my practice.
Oh,
And that too happened in a patient whose creatinine was 3.5 and she was in sepsis. She also survived. So I think it is blown out of proportion. And for no reason, metformin remained banned in several countries. Fortunately, in our country, metformin was never banned.
yeah,
And we always continued using it right from the diagnosis of diabetes. And we have been very firm believer. So I always say that lactic acidosis or metformin associated lactic acidosis is a ghost which nobody has seen, but everyone is scared of.
hmm,
So, of course, you have to follow the contraindications of metformin, like advanced kidney disease, advanced hepatic failure, advanced heart failure, sepsis. So, in absence of that, I don't think lactic acidosis due to metformin exists.
I agree. Uh, it is by going through the med school, it is the only side effect that they predominantly give
Absolutely.
under metformin.
So
So you are
everyone is
under the
scared of
impression.
that
Yeah, I
side effect,
agree.
which nobody has seen.
Mhm. Yeah. Okay, so beyond metformin, which specific class of newer agents do you prescribe, and what are the specific indications that you use?
Yes. There are very good new medicines that have become available in last couple of decades. Of late, the two very exciting molecules. First, the SGLT2 inhibitors, empagliflozin and dapagliflozin, and then the GLP-1 receptor analogs, starting from exenatide actually, and then liraglutide, and now semaglutide. And this have changed the way we treat type 2 diabetes. Previously, we used to treat type 2 diabetes for glycemic control.
Mhm.
It was a glucocentric approach. Now the approach has totally become complication prevention centric.
I agree.
So it is a cardio renal metabolism centric. So when you treat type 2 diabetes, you don't just treat the blood glucose. You treat the patient to reduce the cardiovascular complications, to reduce the kidney related complications, to reduce the liver related complications, and obviously to reduce the weight if the person is overweight. So, this in turn will give you the best quality of life and longevity of life.
Mhm. So, we talked about semaglutide. So, are there any specific indications for which you prescribe a patient semaglutide and you prescribe a patient tirzepatide?
Well, again, that's a great question. I forgot to mention the tirzepatide while talking about the GLP-1 because it's a dual agonist, GLP-1 and GIP. And as far as the glycemic efficacy is concerned, both are same. But as far as the weight reduction is concerned, tirzepatide is probably double as efficacious compared to
Mhm.
semaglutide. The tirzepatide in the maximum tolerated dose can cause about 20-22% weight loss, whereas semaglutide can cause 15% weight loss in the maximum tolerated dose. So, the efficacy as far as the weight loss is concerned is greater with tirzepatide. The glycemic efficacy is equal. From cardiovascular standpoints, still the jury is not out, but jury is out. But at present, the cardiovascular outcome trials are larger with semaglutide, but they are coming up with the tirzepatide also. Liver related, semaglutide has good studies, so has tirzepatide. Obstructive sleep apnea, tirzepatide has better data compared to semaglutide. Kidney, both have very good data, but semaglutide, because it's an older molecule compared to tirzepatide, has more data. So, vis-a-vis, I can say that from weight lowering perspective, tirzepatide has greater data. From cardiovascular standpoint, semaglutide has greater data. Otherwise, both are comparable.
Okay. Any specific indications for glitazones?
Yes, I forgot to mention about the glitazones. They are also one of the important drugs from the cardiovascular preventive point of view. Why I am saying so? Because the proactive trial you might have read was positive from 3-point miss and heart failure apart, but the 3-point miss was positive for pioglitazone in proactive trial. So pioglitazone also has effect on the fatty liver and it is a very good agent from the glycemic efficacy point of view. The only drawback is it can cause weight gain and can precipitate heart failure in a susceptible individual. So you have to be careful. Otherwise, it is also a very good drug.
Yeah. So, let's say that you have gone through all the medications for a patient. There are still some symptoms that are not improving. So, what is that clinical threshold after which you start insulin in a patient?
Okay. Again, that's a very important practical question. But before going on to that, I would just have a few words about diet and lifestyle because they play a great role in managing type 2 diabetes right from the day one and throughout the patient's
I
life.
agree.
Otherwise, patient will have to take more and more medicines and will have ultimately to go on insulin. So, to prevent that happening, diet, lifestyle, and regular checkups play an extremely important role. And here I would like to address this issue by mentioning about our blue index, where we have 10 commandments of type 2 diabetes management, starting alphabetically from A, that is A1C control, that is average glucose control, B is blood pressure control, C is cholesterol control, A, B, C are very well known everywhere. D is dietary modification, and we Asians require real modification because we need to cut down carbohydrates. The simple carbohydrates we take in more than 60% of the total food. We lack in protein supplements, so protein intake should be increased. Exercise. We Indians probably are not very good at exercising. So, exercise has to be included right from the young age or the school age, I would say. And then the follow up of the disease also plays very important role. Following up with your clinician, following up with your daily schedule, following up with your daily monitoring of the blood glucose and the tests that doctor has suggested also play an equally important role.
I agree.
That is F. Then the G is general health. If everything is okay and if you are not happy, we always say glycemic happiness. You have to be stress free, you have to be happy, enjoying the life. Otherwise, you will invite all the complications that you have read. So, the overall health also plays important role. The liver health also plays important role. The bone health, the muscle health, and anemia is also very important in our country. Then the habit avoidance is H. So G is general health, H is habit avoidance. Smoking, tobacco, alcohol when it becomes a habit, all these have to be avoided. And these days there is one very common habit, the mobile addiction.
No.
Or or the social media addiction. So that also has to be taken into account because that will increase your sitting time,
Yeah.
right? Or the screen time. And then the infection prevention is also very important in diabetes. In the era of COVID, we realized that so many of diabetes patients died because of COVID or the infections. So, infection prevention is again important, taking regular vaccinations, especially the influenza vaccination. And then knowing about the side effects of the drugs also plays very important role. So, if you do all this, your quality of life will improve, your complication free life will also improve. Yes, now coming on to your question on insulin. Diabetes, the main reason for development of diabetes is one is insulin resistance in type 2 and insulin deficiency. Absolute insulin deficiency in type 1 and relative insulin deficiency in type 2. So, insulin deficiency or the beta cell defect is also one of the most important reasons why a person develops diabetes. There are several other ways described as ominous octet by DiFronzo and described as sweetening 16 by uh, our group. Uh, but these are the two main reasons: insulin resistance on one hand, beta cell defect or insulin deficiency on other hand. So, eventually, in the lifetime of type 2 diabetes patient, also insulin may be required sooner or later.
Hmm.
In type 1, obviously, there is absolute insulin deficiency, and insulin is mandatory for survival right from the day one of diagnosis. But in type 2, if person comes to you with severe hyperglycemia, say fasting is more than 250, HbA1c is more than 10 or 11, patient is having that osmotic symptoms like polyuria, polyphagia, polydipsia, or if patient is undergoing some surgery or patient is developing some sepsis or infection, patient is hospitalized for some reason, all these conditions, pregnancy, for example, all these conditions require usage of insulin. Sometimes the usage may be short term, sometimes it can be lifelong.
So, is there a trend in pregnant patients that you have seen that has changed a bit? Diabetes coming into play?
Yes, again, it's a very interesting question. These days, we see more of pregnancy related diabetes, what we call diabetes in pregnancy. The broader term is gestational diabetes, but now the term which is used commonly is diabetes in pregnancy. Many of our patients have diabetes even before diagnosis of pregnancy or before the conception because of two reasons. One is diabetes, the persons are now developing at a very young age, as I said, in the early 20s or early 30s. Second is the pregnancy these days, which used to be in the second or third decade, is now sometimes in the fourth decade. In the middle of 35 or 40 years, women are getting their first pregnancy, and this is becoming more and more common in urbanized India. So, this is one of the reasons why we are seeing more diabetes in pregnancy.
Is there uh, any specific area of research that you feel that is upcoming in the field of diabetes?
I think it's a very evolving field. In the last couple of decades, as I said, first the glitazons came, then the DPP4 inhibitors, and then SGLT2 and the GLP, which changed the way we treat type 2 diabetes. In the monitoring, the CGMs, they are really the game changers. Unfortunately, they are a little bit costly for our country, but they are really very, very useful tools for assessing the glycemic control and to improve your lifestyle. Moreover, the newer insulin pumps, which are AI based, so you do not have to do
Oh,
anything but just apply the pump. So, these are the ways through which you can monitor, you can treat type 2 as well as type 1 diabetes with greater precision. And the precision medicine is going to come in a big way once the artificial intelligence and all these new things which are coming up will throw us some light that how Mr. X should be treated, how Mrs. Y should be treated, and how Mr. Z should be treated because these three patients are totally different and they need different treatment.
mm. I just missed out on a question while you were talking about insulin. Uh, Seeing that you are so experienced and you have been practicing since 35, 40 years, uh, have you, what are the differences that you are seeing between the human form insulin and the insulin analogs that we use today?
You're right. Well, insulin is a very important thing. Let me tell you and your audience that insulin is one of the most important treatment available for type 1 as well as type 2 diabetes. Type 1, it is absolutely mandatory. Type 2 also, it is time and again required, but never be afraid of insulin. Previously, the insulin therapy started with bovine insulin, then the porcines came, and then the human insulin, which were manufactured by the genetic engineering using the recombinant DNA technology. Now, human insulins have certain limitations because if it is a long acting version, the effect would not last for more than 14 or 16 hours. If it is a short acting version, it would take at least 45 to 60 minutes before the action starts. So, one has to inject 30 to 60 minutes prior to the meal,
Oh,
which is impracticable in most of the people because we all of us lead very fast life. It's not possible to wait for half an hour and then start eating after taking insulin. And that's why the amino acid sequencing was changed from human insulin to analog insulin, which would make them work faster at will, maybe within 10 minutes or 15 minutes. Ultra rapid acting insulins, you must be knowing, or act longer, maybe for 24 hours or even longer than that. So, analog insulin offer an advantage over the human insulin, especially for the rapid acting as well as the long acting
hmm.
versions.
Okay. So, there's a question that I'm going to ask to all of the doctors that I'm going to interview during this podcast. Uh, is that in today's world, as a young and upcoming clinician, not just me, but all of my other colleagues and my friends who are viewing this podcast, what is the one tip that you'll give to help them succeed in this field.
Okay, great. You must be listening about diabetes reversal, and someone would feel that being diabetologist, you have no career because diabetes is going to be reversed anyway. Well, diabetes can be reversed with very good early aggressive treatment, especially in the people who are overweight if they lose weight.
Hmm.
But still, the lifestyle of all of us has become so erratic and we have become so much diet centric that the diabetes burden of this world is going to grow.
Hmm.
The best way to succeed is catch them early, treat them aggressively,
Hmm.
like power play in cricket. If you treat the disease early on, you will be able to prevent all the diabetes related complications. And if you can do that, you will be the most successful doctor in your field.
As a cricket fanatic, I really like that example. So thank you very much.
Thank you.
And Dr. Sanjeev, please tell me about an interesting case that you have had in diabetes in the 35 years of your experience.
Okay, great. Dr. Aman, with your permission, I'll mention about two cases and not one.
Sure.
One, who incidentally is now my very close friend, came to me with severe hyperglycemia, 500 plus sugar. He was very young at that time, 22 or 23 years of age. And I'm talking about year 1996 or so. And we thought that this is type 1 diabetes. He came with early diabetic ketoacidosis, as I said, 500 plus sugar. We treated him with insulin infusion initially, and then with human insulins. At that time, human insulins had just come. Over a period of time, his insulin requirements went down, and he just needed 2 or 3 units per day. Then we stopped insulin. And then for next 10 years, he remained insulin and oral medication free.
Mhm.
So probably his diabetes was reversed. For 10 years thereafter, he remained diabetes free. Then he started gaining weight and then again he developed a diabetes. This time we treated him with oral agents. He lost weight and again he became
Diabetes.
diabetes free. So this gave us an idea that insulin deficiency in this patient, which was initially there, could be corrected with very good glucose control at that time with early aggressive insulin therapy.
That's it.
And thereafter, again, he could reverse because of the weight reduction.
Mhm.
This is one case. The another interesting case that I would like to mention here is of a 6-month-old child who came to me from Rajasthan, a nearby state of Gujarat, with 500 plus sugar. The doctors from his place referred him to me, thinking that this is type 1 diabetes and the child would require lifelong insulin. But I had in past come across neonatal diabetes cases. So we treated the child on that basis, initially with insulin and then with very low dose of sulfonylurea. And within 1 month, the child became medicine free, diabetes free. And this is, I'm talking about 2 years back. The child is now 2.5 years old, very cheerful child, not having diabetes, very playful. So I always, whenever I see him, uh, my eyes are full of tears that out of happiness.
Yeah.
So these two cases really uh, are very emotional cases, I would say.
Regarding the second case, did the boy have any family history
No
of
family
diabetes?
history. No family history. We did his genetic testing and it came out to be the KC and gene positive, that is a neonatal diabetes.
Oh. Yeah, that's all the time that I have with you. So thank you very much for joining us today. And I had a really insightful talk about diabetes, and it is really given me a clear picture about what to expect when I come across a patient.
Pleasure is all mine, Dr. Aman. It was really very wonderful talking to you.
Thank you.